Next, I'd like to welcome Paul Osterman up forward, please. Paul is the Nanyang Technological University Professor of Human Resources and Management at MIT Sloan School of Management, as well as a member of the Urban Planning School at MIT. From 2003 to 2007, he served as the Deputy Dean at Sloan. His research concerns the changes in work organization within companies, career patterns and processes within firms, economic development, urban poverty, public policy surrounding skills training and employment. Paul has been a senior administrator of job training programs in the Commonwealth and has consulted widely for government agencies, foundations, community groups, firms, and public interest organizations. Paul is going to introduce the panel and convene a lively discussion on home health and late in life care, I guess. And I'm halfway through the book you gave me a month ago.
Oh, well, good.
Thank you, Paul.
Thank you. Yeah, no, I just actually did publish a book on long-term care, which is actually why I'm here. So you just heard, I guess, that if you're under 45, you're more likely to die if you're hit by a car than anything else. But after that, long-term chronic care is what's going to be the big problem. And it's a massive problem. So today, about 13 million Americans are disabled enough so that they need long-term care. Those numbers are going to explode. They're absolutely going to explode as the baby boom ages and goes through this process. But we don't have a system to deal with it. Today, we rely on unpaid family caregivers, about 11 million of them. But the same demographic pattern that is going to create a boom in need is going to depress the availability of unpaid family care. We have about 3 million paid family caregivers. They average about $10 an hour, and they get virtually no training. So you can imagine the implications of that, but we're not even going to have enough of them unless something changes. Long-term care is amazingly expensive. It's about $90,000 a year in a nursing home. If it's full-time at home, it's about $45,000 a year. The system is incredibly opaque, very difficult to navigate, and we simply have relied on muddling through, and muddling through is not going to work going forward. So that's the theme of this panel. We have two terrific presenters. Carol Raphael is currently the senior advisor at Manatt Health Solutions. She's probably the most knowledgeable person in the country with respect to long-term care policy. She was CEO of the Visiting Nurses Service in New York, which is the largest home health agency. She was chairman of the board at AARP. I think she's probably stuffed all those envelopes that you get every week from them. She was a member of the Medicare Payment Advisory Commission. There was a bipartisan commission on long-term care that she was a member of, and I could go on and on. She's going to talk to us about national policy issues with respect to long-term care. But of course, long-term care has to be delivered on the ground. Tom Grape is the CEO and the founder of Benchmark Senior Living. It runs assisted living, CCRC, continuing care retirement communities throughout the Northeast. It's large. It's got 55 facilities, and it's been consistently cited in the healthcare press and actually in the general press also as not just a high quality set of facilities, but also a very good place to work for its workforce. And since long-term care is extremely hands-on, that's a very important aspect of his system. So Carol will speak first, and then Tom will speak, and hope we may or may not have opportunity for questions. So thank you. I don't know what you do or do not have.
I have the
slide clicker thingamajiggy? There you go.
All right, let's see.
Thank you.
Okay, good morning, everyone. I'm going to really help you to understand the landscape of long-term care at this current juncture in our history. I'm going to hopefully convey to you the importance of long-term care, 6 major challenges in the system, and where we're headed in the future. So let me start by just describing what do we mean by long-term care. I think it's really important to understand that it is quite different from other parts of the healthcare system. It's different in its duration, and it's different in the fact that you have to mesh the gears of medical and non-medical care. Who are the people who need long-term care? I was thinking about that this morning. I have a close colleague who was an engineering student in Colorado, had a ski accident at 19 and has been paralyzed since then, but is very active, working full-time, and engaged in his community. I have another colleague in Washington, D.C., who, lo and behold, her husband came down with ALS, and it's completely upended their lives. And I was talking to someone just yesterday in New York who was relating to me that her father, who was a professor of mathematics at NYU, has Parkinson's, and her mother had an accident, fell down the few steps in their home, and had a fall that was a sentinel event and has really changed the texture of her life. So those are the kind of people that all of us know and intersect with. I want to talk about 6 challenges in the system. Paul made the point there are 12 million people receiving long-term care today. I think it's important to recognize that nearly half of them are under 65, and they are a very important component of the population that is being served. And as Paul also, I think, emphasized, the need is growing, and it's driven by demographic changes and medical advances. I don't have to tell everyone here about the fact that we expect huge growth in the over 65 population, but the fastest growing cohort is actually those 85 and over. And half of those need long-term care. And we expect by 2050 that 27 million people will need long-term care. We talked this morning, I think Restef talked about a chronic condition, and I think about this a lot. Because one of the things that has struck me over and over again is the prevalence of chronic conditions as people live longer. Over 50% of the 65 and over have hypertension. Almost 50% have arthritis. Despite the strides in heart disease, almost 30% have heart disease. The prevalence of diabetes is growing and is now over 20%. And it is very common in the long-term care system to find people who have 4 to 6 different chronic conditions. And these are people who definitely begin to develop functional challenges. Get that to go. Oh, thank you. The second challenge is that the insurance coverage for long-term care is insufficient. When I was on the Bipartisan Commission on Long-Term Care, a real eye-opener for me was that it is predicted that 70% of us will need long-term care at some point in our lives. This is a mainstream issue that is going to affect the majority of people living in our nation. And we do not have coverage for long-term care. I think that most people don't realize they don't have coverage. They think the government somehow covers it. They think Medicare covers it, but Medicare covers post-acute skilled intermittent care. And we don't have a viable private insurance market. Only 8% of the $310 billion spent annually is covered by private insurance. 15 years ago, there were 130 private insurance companies. Today, there are only 18. All these companies have left the marketplace. Those that remain are raising the premiums quite substantially. The average 60-year-old male who wants private long-term care insurance would pay $3,300 a year. The average 60-year-old woman would pay $4,400 a year. Most people find it incomprehensible and unaffordable. In addition, I mentioned Medicare not paying. So the major payer for long-term care is Medicaid. It covers over 50% of the costs, and that is not by design. It is by default. It is because most people end up spending down and become eligible for Medicaid. They didn't want to, but they do. And that is because, as Paul also said, long-term care is expensive. A nursing home costs between $85,000 and $97,000 a year, and even care in the home now is up to $45,000 a year. I know from my work at AARP, I never could believe this. I kept reading it over and over and over again, the studies that showed that the average American retired, in quotation marks, with $50,000 in assets. So if that is what they are bringing to the later stage of their lives, you can see the gap between the expected inevitable expenditure and what they have available. Then most of the care, the third challenge, is the workforce. Who is the workforce? There are two parts of the workforce. One part is all of us. 8 of 10 Americans who need long-term care receive it from us. We're called informal caregivers. We're families, we're siblings, we're friends, and we're providing the care. And more than 4 in 10 Americans have provided long-term care. Yesterday, I was interested, we were talking at some symposium about the 42 million people in the course of the year who deliver long-term care. They often provide 70 hours a month of care, which is quite a substantial commitment. What I didn't realize was that 40% are now men, and 10 million of them are millennials. So this is a very diverse group of caregivers. And if you look at this invisible army and monetize what they provide, it amounts to $470 billion. The other part of the workforce is called the direct care or formal workforce, and the supply is inadequate to meet demand. I always look at what are the fastest growing jobs in the United States. And it is clear in every survey I have looked at, among the top 10 fastest growing jobs are home health aide and personal care assistant. They're number 3 and number 4. They're supposed to increase by 47% for home health aide, 37% for personal care assistant. So here are jobs that are growing. We're constantly looking in our economy. Where are the jobs that are growing? These are the jobs that are growing. But the turnover rate is very high, and more people are leaving these occupations than entering it. And why? Paul made the point. The compensation is very low, on average $10 to $11 an hour. It's a tough job. You're taking care of someone, that person goes in the hospital, all of a sudden you lose your income. People receive little training. There's no mobility. Where are they going to go with this job? And it's not valued and respected in our society. The next challenge, the fourth challenge, has to do with how fragmented and complicated this system is. For all of us, it's often a crisis that leads us to think about needing long-term care. And then it is indecipherable. I mean, I get calls from people I think are sophisticated. They're in our state legislature. They're in business community, and they say, oh my goodness, something happened to my father and he's being discharged. What should I do? And so I think that it is really important to understand that access and getting help when you need it is really extraordinarily difficult. But in addition to that, the system is putting great stress on state and federal governments. If you look at Medicaid, and I know we're going to hear more about it later, about 6.5% of the beneficiaries need long-term care, but they account for 55.5% of the costs. So it is this group that is driving the growth in Medicaid. Most states have 20 to 25% of their budget that's accounted for by Medicaid, and this is the fastest growing component. In addition to which, states are trying to figure out how to grapple with this, and there's two things that I'm going to highlight that they're doing in response. One is, we call it belovedly rebalancing. When I started out in this profession in the 1990s, 13% of Medicaid expenditures went to home and community-based services. And that has really changed because states have been really building their home care systems, and it's now 50% of the total that Medicaid spends. So that has been a substantial, I think, directional change. The other change is that many states, 2/3 in fact, are either planning or have implemented managed care systems where they basically use private health plans whom they pay a capitated amount to provide long-term care. And that is definitely a wave that we have seen. I think I'm just going to very briefly highlight this. I chair the Long-Term Quality Alliance, which is an alliance of payers, providers, consumers, policymakers. And we just issued a study which showed that Medicare spends nearly 3 times as much per capita on the 13% of adults who need long-term care as it does on the rest of Medicare beneficiaries. So this is affecting the federal government's expenditures as well. The fifth challenge has to do with quality. The federal government has something called the STARS system. You can get up to 5 stars. If you look, 11 states have 40% of their nursing homes that have 1 or 2 stars. 30% have, 21 states and Washington, D.C. have nursing homes that have 1 or 2 stars. I would say we're in a very early stage in regard to quality. There are multiple assessments, multiple metrics. I don't think we've yet landed on what defines quality of life for people who are going to live with this care for the rest of their days, and to really figure out how to have that core set of metrics that is going to have impact. And the last challenge, I believe, is in technology. Long-term care providers are late to technology. They weren't part of the HITECH Act and didn't get incentivized. In addition, interoperability, which I've been very involved in New York, has really been a challenge in bringing in the long-term care providers. We're beginning to make some important headway. But I think the thing that struck me the most is 90% of people want to age in place. They want to stay in their home. Technology offers the potential to help them to do that. And there are many, many, many companies moving into this space. There's so much activity in telemedicine, in mobile apps, in internet-enabled home monitors. I've just saw some very interesting new application that was FDA kind of vetted that basically used a voice-assisted device to say to someone, how are you doing? Have you taken your medicines? I've seen a number of on-demand transportation services that are very interesting to me because transportation has been a big issue in this field. But the fact of the matter is, I'm here to tell you, penetration is very low. Uptake has been minimal. And I can talk at length about what are some of the barriers and what accounts for this, but there is a gap between what technology is providing and what is adapted and used every day. So when we talk about the future, where are we headed? I've been very involved in quality. I've chaired the National Quality Forum, one of the 3 key work groups on value-based payment and trying to define quality in long-term care. And I see directionally hope because I think there's a move toward patient-reported outcomes. There's much, much more emphasis on function and on making the patient and family partners in defining what matters. What matters to a patient can be very different. They may want to go to a grandchild's graduation, or they may want to be able to continue a PhD program that they have been enrolled in. You need to see the world through their lens, and I think we're beginning to move away from just clinical metrics to some non-clinical metrics. In regard to the workforce, over 30 states have passed what we call the CARE Act, which requires hospitals to include caregivers in the team that they deal with and to prepare and train them. If they have to flush a catheter, if they have to change a dressing, if they have to manage a complex medication regimen, they need to be prepared for it. There are a few states that are moving toward a minimum wage of $15 an hour, and I think there is growing attention to how to use this workforce in a different way to really enable them to contribute more to care so that we can bring down the overall total cost of care. And then lastly, on financing, I could talk at length about this. I've been very involved in trying to find a financing system for long-term care in our nation at a difficult time. And there are 3 groups that have been involved: the Bipartisan Policy Center, Leading Age, and the Long-Term Care Financing Collaborative. And they have come up with some recommendations that I think are very promising. I'm just going to highlight 3 elements. One is to change the private long-term care insurance marketplace, to think about offering it through employers, to think about having a home care only benefit which would reduce its costs substantially, and to having it so that people can understand the benefits and compare plans. Secondly, to thinking about a targeted public solution. So if you need long-term care for a year and a half or 2 years, you're going to pay on your own. But if you need it for more than 2 years, then the public benefit would kick in, because then it would be construed as catastrophic. And lastly, kind of shrinking the role of Medicaid, but still keeping it as a safety net. So I would like to leave you with the following takeaways. The need for long-term care services is significant and growing. It's going to affect all of us. It's a family issue. And it's going to affect our society, and it's going to affect our state and federal governments. The coverage and financing of care is insufficient, and people are unprepared for this inevitability. Thirdly, the supply of formal caregivers does not meet demand and will not, as it's currently construed. And I think finally, the role of informal caregivers is beginning to get attention. The fragmented delivery system makes it difficult to navigate and understand, but I think it also contributes to increased overall costs, and we could be so much more efficient in what we're doing. States have become laboratories. They really are the ones trying innovative new models and really crying for more flexibility to be able to do that. I think quality measures, as I pointed out, are beginning finally to move toward the non-clinical, patient-centered, family-centered part of the spectrum. I think there are some new market entrants in this field. They're very interesting to me because I think they're thinking about how to leverage technology and how to create new caregiver roles that really support the consumers who want to live independently. And lastly, I turn to all of you. The future of long-term care needs creative solutions and very significant reform. Thank you very much.
Thank you, Carol. Tom, you're on.
Thanks very much. That was a wonderful overview. I'm pleased to be here. I was asked to focus a bit more narrowly on workforce issues, which I will do. As Paul mentioned, we've got 55 communities in the Northeast. One comment I'd add to the average costs that you saw that Carol presented, the costs in the Northeast are all a good bit higher than those averages, as you'd expect. But that was a wonderful overview. Thank you, Carol. So a couple of things I'd begin with is the healthcare landscape, as we all read about and hear about in the papers every day, is changing dramatically before us and with great uncertainty. But it's causing everybody in the healthcare world, and actually we're sort of in the long-term care system, clearly as Carol defined it, we are, but our company, our communities are all privately paid. So we're not part of Medicare or we're to a very small extent in Medicaid, but we're basically privately paid. So we're not part of some of the issues that Carol's overview touched on. And yet we're sort of on the periphery of the healthcare system because we get referrals from hospitals, we refer to hospitals and so on. And yet we're certainly affected by what's happening in the healthcare discussion nationally. Everybody in and around the world of healthcare is obviously watching with great interest or affected directly or indirectly by what's happening with the conversations about the healthcare environment, and we're certainly affected by it, watching it very closely, and we expect to be actually an increasing part of it going forward, whether financed by it or not. But the healthcare climate is changing dramatically. Secondly, everybody in healthcare, again, directly or indirectly, clearly knows that digital and technology solutions are going to be more and more a part of our lives and will help with some of whatever the solutions may be in the future. It clearly will be affected by many of the things that you're talking about today. There's some interrelationships here that some folks don't quite see as they are, and that our view is that these things are all interrelated, that long-term care is both driving some of the digital innovations and being affected by and driven by the digital innovations. The healthcare ecosystem is affecting long-term care is affecting the healthcare ecosystem, and same between digital innovations and healthcare ecosystem. Some of the examples, there's a long list, but just a few examples that have resulted from some of this interactions are things like telehealth, telemedicine, tremendous application for what we're doing, and certainly folks in the home. We think that's just beginning to get traction. There's a much more application, certainly for people who are interested in staying at home, or for communities that are community-based services and senior living communities that may not be a part of or on campus with a healthcare network. Real-time location systems, which we've gotten some great early experience with, where we can actually monitor real-time the location of residents, particularly helpful in a memory care environment where we're concerned about potential wandering risks for folks with dementia. Fall prevention. Falls are a tremendous issue for folks in the elderly population. So wearable technologies or fabrics with technologies woven in are tremendously helpful for being able to either monitor falls, or even better yet, when we get to the stage of being able to predict falls. Not quite in a great place about that, but we're getting there. Is going to be a huge help. And finally, some of the technologies about virtual and augmented reality are helping. And again, in early stages, there's a long list, but these are all things that we're seeing and will benefit from both today and in the future. Carol touched on the point about the dramatic demand for workforce. There's a tremendous reduction. One of Carol's slides, I don't think you made the point, that AARP today's is the ratio of caregivers to elders today is about 7-to-1. It's predicted to drop to 3-to-1 in 2060. That's going to be a huge national issue for us. One of the trade associations, Argentum, predicts there's a demand for caregivers of about 1.2 million additional paid caregivers over the coming several decades. Actually, we just saw a news article this morning from Bloomberg that said, what did it say? It said that robots are coming for jobs of as many as 800 million worldwide. And it said that even if the rise of the robots is less rapid, some 400 million workers could still find themselves displaced. The good news for those displaced is there will be jobs for them to transition into, although in many cases they're going to have to learn new skills to do the work. Those jobs will include healthcare providers for aging populations and a couple of others. So there we go. Folks who will be displaced by robots can come work with the elderly. So some of the things that we think about as we're looking at this workforce challenge is the technology applications have been helping really on the demand side. We've seen, obviously, there's been a growth for a number of years now in the aging population. The curve is sort of like this. It's going to really skyrocket with the baby boomers coming in the next 15 years or so. There's already been an increase in acuity. We see the average age, for example, coming into our assisted living communities has increased in the, from roughly 10 years ago, or 15 years ago, it might have been 81 or 82 at admission. Today it's about 86 or 87. They're coming frailer, they're coming with more chronic conditions. And that's a national trend. So the average resident we're seeing now is more frail, has more need for assistance with activities of daily living or instrumental activities of daily living. So that's an opportunity for help with technological applications. And regulators are looking for better records and better coordination among parts of the system and so on. So those things have already been happening. When we see, of course, the aging population and higher acuity has been happening up and down the healthcare continuum. We know that hospitals used to have people stay for longer periods of time than they're staying now. Hospitals are now very quick turnarounds. Nursing homes used to be called long-term care settings. They're now all very short turnaround rehab type settings. Who used to be in hospitals are now in nursing homes. Used to be in nursing homes are now in assisted living communities and so on. So this is those trends are expected to continue. On the supply side of workers, the labor shortages, again, are happening today and are going to expected to become more acute. And as Carol alluded to, turnover of workers because of the comparatively low wages and the transient nature of some of the types of workers we have is a continuing nagging issue. And we're expecting that there will be a number of technological applications that are helping and will continue to help with those issues. There's social media applications that help with recruitment and communication and retention with workers. There are communication tools that will help us with workers. There are improved selection tools technologically that will help us select the right workers. There's a whole host of technology applications that will help us with the coming labor shortage. So some of the ways that we're approaching the changes in managing the workforce is, first of all, we need to have a culture with folks that understands that there's change happening today at a faster pace and more coming. And we also, our work environment, people have typically thought of long-term care in general as not being a fast-paced, sort of innovative kind of environment or culture, and that's changed and is changing and is going to continue to change more in the future. And similarly, the impact of technology and role of technology, a lot of our folks come without sometimes a computer at home or without a smartphone that they have with them. We're going to need folks with increasing technological skills, and so we're going to have to provide more of that training ourselves and look for either workers that come with those skills, or we're going to have to help train them in that way. Organizationally, we're going to be looking for folks who may have some specialized skills or who are going to be working in specialized care teams more frequently as, again, the acuity continues to increase and as we look for higher personalized care models. And we're also looking for moving to more flattened hierarchical structures so that we can reduce turnover and so on. We think technology can help in three particular buckets. There's physical ways, some of the physical tasks of two-person assists, for example, getting folks out of their bed to get them in a wheelchair if they require that. We actually just saw another press release this morning, which doesn't apply to two-person assists, but the first, a dental transplant was conducted by a robot in China. The article came out this morning, so technology is doing all kinds of things. Use of exoskeletons, where folks who may have mobility issues can have help with walking and otherwise transporting with, and a lot of that work's, of course, being done right here. Robotic machines to help lift off of toilets, for example, or out of chairs. Those are all things that are happening today and will become more and more commonplace. Second bucket is the mix of physical tasks, help, and service help. So again, we mentioned telehealth and telemedicine. Isolation, of course, GBO is a product that was born here on MIT, and we have a couple of GBOs in our office. Those are home-like companions, social robotic companions that are going to become very popular and very commonplace in the coming years. That will help remind folks to take medications and provide companionship and help schedule appointments and do a variety of much more sophisticated tasks, but those being some that are immediately applicable for the elderly, either staying at home or in senior living settings. And finally, service-oriented tasks, which things like, for operators like ourselves, both the sort of back-of-the-house functions, things like accounting functions and scheduling of staff functions and so on, as well as more direct consumer-facing functions, which will grow over time as the robotics get more sophisticated. And so here's a chart speaking to some of the back-of-the-house functions like accounting and HR functions that a lot of robotic capabilities exist for today. The higher touch functions we will sort of bleed in over time as the capabilities grow from the robotics in either perhaps some direct care things or customer experience things, or there's some dining applications that exist today. Over time, we think those will, as those get more sophisticated, those will play a higher and higher role in perhaps taking over some of the functions of staff. A lot of them aren't quite at a point where we'd want them to do that yet, but they're going to be coming in the years ahead. And again, this sort of makes that point that the percentage of tasks that are being done by humans is sort of the darker blue, and those that we'd sort of be comfortable with having be automated is the green, and we again think that percentage will be dramatically changing in the years ahead. This makes the point of these smart units really meaning sort of apartments, if you will. We're actually opening, we opened a new property, a new community in North Attleboro 2 weeks ago. We're having the grand opening for it today, which features some new technologies, including lighting that's programmed to have lower lighting levels at times of the day, because falls, for example, when folks when an elderly resident goes from their bed to the bathroom, is a frequent incident when somebody might have a fall. So we've got lighting programmed to be at a lower level overnight. Simple thing, but it actually we think will have a meaningful difference to reduce falls. We've got Google Home programmed in the apartments, which we think will help with some of the basic tasks that Google Home does. We've got some other interesting things that we're starting to apply in the senior living community setting that can be further applied there. It also, of course, will be applicable in home settings. So we're starting to see smart senior living communities that also, of course, can be applied at homes. The GBO examples of the personal companion units I mentioned before, those can be applied in senior living communities as well as at home. And then the long-term care expertise for catastrophic events or otherwise, where somebody, an ambulance might be called before the staff even knows about it if we have the right kind of connections with the technology and the resident with a wearable device or the like, and the files can be transferred to the healthcare provider that they're being sent to and the like. So all of these things are either available today or happening within reach and can be put both in homes as well as in senior living communities, which will help with quality of care, quality of life, staffing efficiencies, and the like. This is a different point, which is while adoption, I agree with Carol's point, adoption is low among seniors, that their appetite, their interest in it is high, but the gap is, at least the way I would describe it, is a lot of the devices that we've seen to date have been created by technologists, not necessarily done in concert with either consumers or providers. So they're not quite as user-friendly as they might be. That, of course, will shift over time, but the appetite for the seniors have for tech, what we hear is reasonably high, but the ease of use is not quite where they'd like it to be. But We actually do have online helpers at each of our communities for folks, for the seniors to communicate with their families, and that's been resoundingly popular. And so these are simply some statistics about the seniors' use of technology, which we found to be reasonably high. And then finally, some of the digital innovation requirements we see, many of which have been already discussed today, but efficiency and integration, the interoperability issue, of course, is a huge one. Some of the design characteristics that have been spoken about. Legal challenges is actually a very big one because the ability to share information, the biggest challenge there are some technological challenges, of course, but the biggest challenge there that we see is legal. Is HIPAA data is actually one of the biggest issues in being able to share information as much as we would like between providers. So those are my comments. Thank you.
So I want to actually ask Carol and Tom a provocative question. Who wrote the Book of Love? No, that's not the question. So we see what the numbers are in terms of the explosion of need and the aging of the baby boom. Tom runs high-quality centers, but they're private pay. And I assume that they're private pay because Medicaid, which is the largest payer in the system, reimbursement rates are terrible. And so it's on average about 65% of what Medicare is, for example, for a doc. So it's hard to provide quality at those reimbursement rates. Technology can do things, and as we've just seen, but it strikes me, and this is the provocative question, that the big fix has to be a rethinking of the system as a whole and the development of some kind of political will to rethink the system and make it work for the tens of millions of people who are going to need it, tens of millions more people who use it now. What is stopping us from really fixing this as opposed to kind of playing around the edges? Because, I mean, a lot of this is playing around the edges, in my view.
Well, I would say there are several factors. One is I still think it's seen as an individual problem. I was talking to someone in Congress, and he was saying to me, I have to go home to my state because my mother, who is 98, is having a problem. And he was depicting it to me as his individual problem. And he wasn't seeing it as a societal issue, that he does not stand alone, that this is a huge problem for us as a society. So I think redefining that, I think, is important. Secondly, that you hit the wall on economics and sort of the view, if we were to make this kind of a public benefit, it would be unaffordable. We're already grappling with what will be the future cost of Medicare and Medicaid and what are the implications for our society. Will we end up incurring more debt, et cetera? But I remain cautiously optimistic because I think that Medicare has added new benefits. We did add a drug benefit, Part D. We did add a hospice benefit at some point, which was a new benefit. And there are moves now in the Chronic Care Act and among a number of others to think about within Medicare having a very limited home care benefit that would be up to 20 hours per week for people who really had very substantial functional issues, which would be paid for with a combination of premiums and an enhanced tax rate. And I think it is possible also to step back and think differently about the private insurance marketplace and how to make that marketplace broader and therefore more affordable. So I think it really is raising consciousness, making this a societal issue, making it a family intergenerational issue. It is not just about older Americans or younger disabled people. The average person who provides care also provides financial support to the tune of $7,000 a year. And there are quite a few people who have to reduce their hours of work or even step out temporarily from the workforce because of this. So it does affect the entire economic stability of a family.
Tom?
I would agree with Carol's point that it needs to be viewed as a holistic problem, a societal problem. And I also agree that I think there are going to be pieces that we'll get. I don't believe, I'm not optimistic about there being a wholesale solution that will be funded by the government, but I do agree there'll be some added benefits here and there. I do agree that I think the long-term care insurance market, I think, is a logical place that should be a big part of a solution. I think there's a lot of other ideas that I think have a lot of hope that the government can help, but not be the solution. Things like a 401k kind of equivalent for retirement funding. The whole idea of retirement needs to be revisited because now, of course, people are spending a third of their lives in the post-65 years, and that people haven't really sort of wrapped their heads around that. The country hasn't really wrapped their heads around that.
What
The
about
idea of deducting things like, property taxes for allowing elders to deduct property taxes, for example, from their taxes, or there's a whole host of economic ideas that would allow folks to have some.
Yeah, I want to raise one more question. I'm such a pig. But we haven't talked about the medical care system as a whole. So gerontologists are, I think, the worst paid specialty in medicine. Doctors don't treat, and I say this based on a lot of work I've done in the field in this, tend not to pay too much attention to home care aides or to certified nursing assistants as sources of information about their patients. There's a great deal of tension between different occupations who touch on these patients and in terms of scope of practice. I mean, there's something about the medical care system itself which needs to be rethought. That was not a question, that was a comment.
So, I mean, I think we should recognize that there is a huge shortage of geriatricians. I was on an Institute of Medicine now, National Academy of Science group that looked at the workforce for aging America. And geriatricians are paid the lowest annually of all specialties. And it's a difficult role because it's not glamorous. You're not going to find a cure. You have to deal with people who have incontinence, who have cognitive impairments, who are depressed. And you have to put together, as I said earlier, a number of chronic conditions and make sure that people are being monitored and have the best outcomes. So we should just recognize the context here.
Okay. Yes, ma'am. Yes, you.
Yeah, it seems to me that a lot of the interventions that can really improve health outcomes among people in long-term care are pretty low-tech solutions like improving nutrition or functional mobility or maintaining connections to the community. Do you see payment reform toward incentivizing those kind of interventions and or integration with technology providers that will facilitate more lifestyle medicine approaches to care?
I would say that for a lot of folks in the long-term care system, they're probably past that. People who are in skilled nursing facilities, for example, well, everybody would benefit from those examples. They're usually there because of a traumatic incident. They've had a fall, they've had something that's prompted them to need more intensive medical care. People who are at home or in, those are all good things that might help people, may help some people either defer or perhaps avoid admission to a skilled nursing facility. So I think those are all good things. And I think the whole healthcare system is trying to move to a more preventive model, and that's all a good thing.
I would just say that, you know, in my observation, I think there is sort of the emerging recognition that, for example, for people who are in their home, who want to be autonomous, they want to be in control, they want to have a life of purpose and dignity, no matter what age they are, that there are things that really matter. Social isolation really matters. If you've lost your partner, if you've lost your contemporaries, if you are in a new setting, it is really hard to be alone so much of the time. And we know that now that social isolation correlates with health status. So I think there's the dawning recognition that there are other factors that really contribute mightily to quality of life. but I was just at this session on age-friendly primary care, and I was talking to a number of primary care physicians, and they were telling me that their average visit is between 7 and 15 minutes. So in the course of that average visit, it's very hard for them to turn to the person and say, well, how are you doing? How are you really doing? Like, what's going on? And so you have to have a system, I think we started out with this morning, that really identifies just a whole set of factors that you need to be attentive to that the physician doesn't have to necessarily follow up on. It could be a nurse practitioner, it could be community health worker or a coach. But you have to have a different mindset about what matters and what you need to be attentive to.
Great, thank you.
Thank you, Paul, for assembling this panel to address this somewhat sobering topic. Thank you.